Good morning, good afternoon, good evening, everyone, depending on where you are. Happy World Family Doctor Day. Feliz Dia del Médico Familiar. So today, welcome to our special webinar celebrating World Family Doctor Day 2025. My name is Dr. Cheryl Chen. I'm a family doctor in Hong Kong and WONCA's YDM lead, and I'm honored to be a host and moderator today. We are thrilled to have you join us for this important discussion on mental health and well-being for family doctors worldwide. As you all know, the theme of World Family Doctor Day this year is Building Mental Resilience in a Changing World, which highlights the important role family doctors have in taking care of our patients' mental well-being. However, we easily overlook the mental health of family doctors ourselves. Therefore, today's YDM webinar is titled Self-Care for Family Doctors, Avoiding Burnout and Building Resilience. As early career doctors, many of you may face unique emotional and professional pressures and challenges, especially in under-resourced and high-demand settings. Our aim today is to provide you with practical self-care strategies and foster a sense of peer support. Today, we'll hear from 4 esteemed presenters who will share their insights and experiences. Now, let's dive deeper into our program and introduce our esteemed presenters. So our first speaker will be Dr. Alejandra León Solarte. She is a specialist in family medicine and an associate professor at the Pedagogical and Technological University of Colombia. Dr. Alejandra has a strong commitment to medical education, and she is actively involved in research focusing on burnout among family physicians. She serves as the representative of Renakai Latin America in WONCA Iberoamerica, and she is the coordinator of the scientific committee of the Colombian Society of Family Medicine. Today, she will give us a presentation on the topic of family medicine's burnout, exploring key findings from our Aspire Burnout Survey. Please join me in welcoming Dr. Alejandra.
Okay. Well, good day to everyone. My name is Maira Alejandra León. I'm a family physician from Colombia, as Cheryl said. Well, it's a really honor to present on behalf of the Aspire global team of YDM of WONCA. This group is led by Dr. Bisan Maraka from Palestine and supported by our global leader, Dr. Cheryl Shan, who encouraged and motivated young family physicians around the world to assess the current situation through the stress and burnout questionnaire in family physician. Well, so in this study, this stress and burnout questionnaire in family physicians, it was aimed to assess the perception of stress and burnout among family physicians in various WONCA regions and providing a global and updated view of the well-being of our profession. The survey was conducted from September to December 2024 among family physicians worldwide, obtaining 281 responses. The geographical distribution was broad. Asia Pacific, 23%, Iberoamerica, 19%, Eastern Mediterranean, 15%, Europe, 14%, Africa, 7%, North America, 10%, and South Asia, 12%. So the questionnaire was answered by these people. The sample consisted of 65% women and 34 men regarding marital status. 65% were married, 28 single, and the rest divorced or widowed. The majority were in the governmental sector. It was about 58%, followed by the private sector, 26%, and a smaller group in both sectors. Regarding the work environment, 27 work in hospital, 26% in group practices, and 14 in solo practice, and the rest in combination of these scenarios or in universities too. As you can say it about the lifestyles and habits, 87. Sorry? Do you want to say something, Anna? No? Okay, so the 87%, as I said, of the respondents know smoke, and only 9% reporting currently smoking. Regarding alcohol consumption, half of do not drink, and only 9% do so at least once a month. In terms of physical activity, this is the next slide. Sorry. Sorry. So I said that in terms of physical activity, the weekly average was 1.1 session of a strenuous exercise, 1.8 of moderate exercise, and 2 of light exercise. So about war-family conflict, the conflict between work and family life is really evident because 45% of physicians think about work at home fairly often, and 17 always. 45% report that their work schedule interferes sometimes with their social or family life, and 37% fairly often. On the other hand, 40% feel that work leaves them too tired to share with family or friends fairly often, and 15 always. Well, about the perceived scale of stress, the PSS-10, well, stress is a constant because the 46% feel sometimes upset by unexpected events, and 27 fairly often, and 36 feel sometimes that they could not control important things in their life, and 24% fairly often. So it's a really problem because 34% feel sometimes nervous or stressed, and the 30% fairly often. Well, so burnout, according to the Maslow burnout inventory, so the MBI assessed 3 dimensions: emotional exhaustion, dispersonalization, and personal accomplishment. And this is the results in these 3 dimensions. So to analyze this, about the emotional exhaustion, the 18% of the participants feel emotional exhausted several times a week, and 10% every day. The 24% feel worn out of the end of the day several times a week, and the 16% every day. On the other hand, the 20% feel tired when starting the day several times a week, and 9% every day. Regarding the dispersonalization, this is not as usual as the first one, but the 38 never treat colleagues or patient impersonally, fortunately, but the 9% do so several times a week, and 30% every day do this. On the other hand, the 27% feel they easily understand their colleagues several times a week, and the 23% every day. Wow. Regarding the personal accomplishment, the 30% feel they positively influence others several times a week, and the 20% every day. The 23% feel that they achieve rewarding objective and several times a week, and the 12% every day. Well, our analysis and reflection is that the results show that burnout and stress are frequent realities among family physicians, with a significant proportion reporting emotional exhaustion and difficulties balancing work and personal life. So, however, a high perception of achievement and ability to positively influence is also observed, suggesting resilience and professional commitment. Where family conflict, fatigue, and stress are cross-cutting challenge in all regions, although must maintain healthy habits and a positive perception of their professional impact. Our conclusions and recommendations. So burnout in family physician is a global, multifactorial, and persistent phenomenon. It is essential that organizations, scientific societies, and health authorities implement prevention and support strategies, promoting self-care, reconciliation, and professional recognition, as WONCA do, and as the YDM team of WONCA, we reaffirm our commitment to the well-being of family physicians and the promotion of healthy work environment. Well, so thank you for your attentions, and I'll be available for question and discussion. Yeah.
Thank you very much, Dr. Alejandra, for the presentations on the burnout survey. We have all learned a lot, and thank you so much for the Aspire team who have done wonderful work in conducting this burnout survey. And we look forward to future collaborations and future initiatives brought by this burnout survey. Our next speaker, we are happy to have Dr. Mya Win Hnit. He is the academic director of the Myanmar Academy of Family Physicians and the Aspire regional lead for WONCA Asia Pacific region. Dr. Mya is dedicated to advancing family medicine in Myanmar and has conducted numerous workshops on physician well-being. In his session, Tips to Prevent Burnout, he will share practical strategies that can help family doctors maintain their mental health and resilience. Let's give a warm welcome to Dr. Mya from Myanmar.
Hello, everyone. Can you hear me well? Okay. So thank you, Dr. Cheryl, for your kind introduction. Good day, good afternoon, and good evening to you all. Today, I would like to share with you the tips to prevent burnout. So before we begin, I would like to highlight that this is not a professional coaching or a therapy section, and this doesn't represent any of the opinions of my affiliated organizations. With that being said, this will be the outline of my presentation, and I would like to start with the three main symptoms of burnout that you have already learned from the previous presentation of the first speaker, which are emotional exhaustion, depersonalization, often representing as a reduced ability to empathize with others, and reduced professional accomplishment or personal attainment. So to address these symptoms, there are several kinds of interventions which are commonly researched, and they can be generally grouped into individual interventions and the organizational interventions. So first of all, let's see what are the commonly researched individual interventions, which includes a professional coaching and psychological interventions with the mindfulness elements, discussion groups, and educational strategies. So how about the organizational interventions? The organizational interventions include the flexible work and scheduling changes, job and tax modifications, participatory and enabling workplace changes, and changes in the physical workplace. So how about the evidence behind these interventions? The evidence for the individual interventions were analyzed in a recent systematic review and showed that most of the individual interventions did provide a statistically significant improvement in emotional and exhaustion and depersonalization. However, these improvements are not really as clinically significant, and unfortunately, no significant difference was found in a professional accomplishment domain. So the reviewer of these individual interventions suggested that the effective intervention should be based on the underlying causes of burnout for individual persons. Okay, so how about the evidence for the organizational interventions? The strongest evidence is for the job and tax modifications, which improve the emotional exhaustion and depersonalization, supported by 3 clinical trials, and the flexible work and rescheduling or the scheduling changes improve emotional exhaustion with a moderate level of evidence, and changes in a physical workplace also help in improving the burnout. And with some of the organizational interventions such as participatory and enabling workplace changes, such as the small group discussion among healthcare professionals, tends to reduce the depersonalization, but evidence is still insufficient. So how should we prevent burnout? So I already presented to you the interventions and scientific evidence. Now I would like to give you some of the practical tips that you can apply for yourself or share with your colleagues. First of all, you need to check whether you have these burnout symptoms or not. Okay, so how could you check? So the first presenter already mentioned about the Maslach burnout inventory, which also can be used for your self-testing. And you use the inventory, you can Google it, and you will get a form, and you can test for yourself whether you have symptoms of burnout. And if you have any symptoms, you should identify the possible causes. And of course, it's very advisable to set the boundaries in your workplace, and you should always prioritize what matters most. And the most important thing of all is the self-care. And as the Dr. Cheryl already mentioned in the introduction, that as a family physicians, we often tend to neglect our self-care because we always think our patients in the first place. So it's also very important to take care of ourselves, to recharge our physical, emotional, and spiritual energy. So the self-care, you will learn more about it in the next speaker's presentations. I will just touch for a few areas of self-care, like you need to have a good sleep, proper nutrition, exercise, and social connections. So exercise really matters, whether be it physical exercise or the mental exercise. And it's also advisable to train your brain to improve the cognitive flexibility, or broadly known as a psychological flexibility, which is also proven that it is directly associated with reduced burnout symptoms. And also, always don't hesitate to ask for help, be it from your family, your friends, or your colleagues. So in summary, today I presented you the practical tips. However, unfortunately, there is no one-size-fits-all strategy for burnout prevention. And the awareness of the symptoms and identification of underlying causes or the predisposing factors will be the important initial steps in preventing the burnout. And always remember that you are not alone. And keep reminding that you're not alone will help you keep away from the why me thoughts. And it will help you build in your mental resilience and prevent burnout. With that being said, this is references And thank you very much for your kind attention.
Thank you very much, Dr. Mya, for sharing with us some very practical self-test tool for us to test whether we are burnout. We can all try out the questionnaire. And thank you for the practical tips to avoid burnout. Let's go to the next speaker. Our third speaker is Dr. Liliana Villegas Baldomero. She is a specialist in family medicine at the Saveriana University of Cali, and an epidemiology expert from the University of Rosary. Dr. Liliana is also an undergraduate medical professor at the St. Martin University Foundation, where she teaches medical clinics and conducts research. Today, she will discuss key points for self-care in mental health and will present this important topic in Spanish. We are very honored to have Dr. Ana Perez to be our translator. So if you go to the three dots in your Zoom bar, there is an interpretation function. You can choose what language to listen to. So you can choose to listen to English. So Dr. Ana Perez will be translating from Spanish to English. Thank you.
Buenos días. En el día de hoy les voy a hablar sobre los tópicos relacionados con la salud mental y dentro de este abordaje voy a tener en cuenta el documento del Plan de Acción para la Salud Mental de OPS, donde están establecidos que dentro de la salud mental hay un grupo de estrategias y acciones que ya están proyectadas hasta el 2030, que se establecieron en la 65ª Asamblea en el 2012 y donde hay unos lineamientos conjuntos que como países debemos alcanzar, partiendo de que la salud mental, dentro de lo que voy a definir en esta ponencia, está definido como ese estado de bienestar en el que el individuo realiza sus capacidades, supera el estrés normal de la vida, trabaja de forma productiva y aporta algo a su comunidad. Entonces vamos a tener en cuenta esa definición que es la que está en el documento. Entonces dentro de ese plan de acción, ¿qué es necesario o qué debemos reforzar dentro de los objetivos? Podemos ver que este plan de acción nos invita a que nosotros tengamos muchas capacidades de liderazgo, de gobernanza, para impactar desde el sector político. También digamos que es muy importante la parte de investigación en salud mental. Sabemos que hay personas que no les gusta la parte de investigación, pero vemos que a partir de estos protocolos tenemos que al menos saber manejar y leerlos, porque a partir de esos protocolos y todas esas cosas que van saliendo desde la investigación es que podemos optar por dar lo mejor posible a las personas que estamos atendiendo cada día. Y lo otro, pues que también es importante que nosotros tengamos en cuenta pues todas las estrategias dentro de promoción y mantenimiento de la salud relacionadas también con la enfermedad mental, porque vemos que las personas que pueden tener otras comorbilidades como VIH, hipertensión, diabetes, que de pronto estamos viendo en los servicios, pues dentro de esas también se va a ver un impacto si estos tienen algún componente dentro de la parte mental. Y muy importante también la parte comunitaria y el rol que nosotros como médicos familiares podemos desarrollar en los diferentes espacios comunitarios y podemos también impactar desde esa educación que podemos dar centrada en las familias, en las personas y en la comunidad. Entonces es muy importante tener en cuenta que dentro de esos puntos claves hay una serie de interacciones que tienen unos antecedentes dentro de esa alta prevalencia de enfermedad mental que hay actualmente a nivel mundial y sobre todo dentro del abordaje que se está haciendo, porque vemos que hay unas brechas tanto en la parte financiera, también en la parte, digamos, de información, de actualización de bases, también, digamos, del diagnóstico de estas personas. Por ejemplo, revisaba que en los países muy desarrollados, el promedio de inversión desde los gobiernos para la salud mental por persona está por debajo de $2, al mes y está en los países en vía de desarrollo por debajo de $0.5. Entonces realmente la inversión es muy bajita y vemos también cómo las personas que tienen trastornos mentales graves, dentro de esto hay una estimación de que en los países en vía de desarrollo generalmente hasta el del 75 al 85% puede ser que no tengan buenos seguimientos o buenas adherencias en sus tratamientos y en los industrializados vemos que esto podría llegar hasta el 50%. Entonces vemos que es una carga de enfermedad grande, que el impacto es grande y que nosotros dentro de nuestra especialidad podemos hacer esta conciencia y como parte de hacer esta conciencia es que en este año de lo que ha estipulado de WONCA, pues estamos celebrando el Día del Médico Familiar, teniendo en cuenta todos estos preceptos de salud mental y nos hemos unido dentro de todos los movimientos, pues para hacer esta concientización que requiero es muy importante para que nosotros podamos ver cómo podemos generar esas estrategias, conocer también como qué se está haciendo dentro de nuestras organizaciones y qué podemos, digamos, poder implementar dentro de lo que nosotros día a día vemos. Entonces, ¿qué acciones son importantes como para ir haciendo hincapié dentro de estos puntos claves? Uno, pues que tenemos que estar en capacidad de hacer estos diagnósticos tempranos, promover pues que esos tratamientos sean oportunos, que sean óptimos, que los pacientes y las personas que tienen esos componentes pues logren tener unas buenas adherencias. También tenemos que tener en cuenta que la parte física no es solo lo que vamos a mirar en el paciente, sino que hay una parte espiritual, hay una parte emocional, hay otros preceptos y otros determinantes que pueden tener impacto dentro de lo que presentan estas personas. Ahí es donde juega un papel importante los determinantes en salud, determinantes dentro del tipo económico, social, todo esto, pero tener en cuenta que en los diferentes espacios donde nosotros estamos como médicos familiares, que principalmente es atención primaria, pero dentro de otros espacios y otros niveles, nosotros también podemos hacer esta detección, podemos hacer este diagnóstico, podemos hacer la captación de estos pacientes e ir alineando para que se les haga unos buenos tratamientos de apoyo que ojalá sean multidisciplinarios. Entonces, dentro de esto, pues la parte de detección y diagnóstico, hacerlo muy temprano es muy importante, recordando que nosotros como tal somos cuidadores de la salud y que tenemos que tener como dar esa alerta desde la parte emocional de esas cosas que vamos viendo pues a la par con los pacientes. Lo otro que también es importante es que hay unos factores que sabemos que influyen en esa parte de la salud mental y ese bienestar. Hay muchos factores estudiados, pero hay unos muy importantes que a lo largo de la vida van a tener trascendencias, como son que como personas podamos tener una participación, una inclusión social, teniendo en cuenta que aquí cuando hablamos de redes sociales, no es tanto, digamos, como las redes interactivas, Facebook, Instagram y todo eso, sino más que todo relacionado con espacio de vida, es decir, por dónde se mueve esa persona, su familia, como la interacción con su espacio de vida secundario, es decir, sus vecinos, sus amigos, sus redes sociales terciarias dentro de las instituciones de salud. Lo otro que es importante que se ha tenido en cuenta es la parte productiva, que a veces va muy ligada no solo a las oportunidades, sino también al nivel de escolaridad, que como vamos a ver, ha tenido impacto dentro de algunos estudios. Hay factores personales también que van a influir, como que yo lleve una alimentación balanceada, que tenga una buena actividad física, deportiva. Y lo otro también que vamos a tener en cuenta es que la parte de hacer voluntariados, meditar, todo esto también se ve que ha sido trascendental y ha sido significativo dentro de lo que se puede hacer. Hay que tener en cuenta que hay unos grupos de riesgos que ya se han establecido, sobre todo esos grupos de riesgos relacionados sobre todo cuando hay mayor componente relacionado con suicidio y algunos trastornos que son de verdad que se han considerado como tal graves, pues hay que tener en cuenta que se da sobre todo, más que todo en poblaciones, digamos, y en edades extremas, muy relacionado con los adolescentes que tienen comorbilidades o coexistencias con farmacodependencias, problemas a nivel familiar, pocas redes de apoyo, que no estén escolarizados, y en los adultos mayores vamos a ver que se ha visto que dentro de los grupos de riesgo están generalmente las mujeres, a mayor edad tienen mayor riesgo de tener esta parte mental, los problemas relacionados con el aislamiento social, a veces cuando hay desigualdad en la parte de las oportunidades también, y vivir en algunas zonas, los inmigrantes, los miembros de minorías étnicas y personas que se encuentran con alguna discapacidad, sin olvidar los cuidadores también están en un riesgo alto. Recordemos que hay algunas escalas que a nosotros desde atención primaria nos permite ver cómo está el cuidador, por lo menos la escala de SARI, que las podemos aplicar y nos puede dar un perfil del riesgo que puede tener en ese momento esa persona. Y por ejemplo, para el adulto mayor hay escalas como de Yesaba que podemos ver el riesgo de que esa persona esté con un proceso depresivo antes de que llegue a ser. Entonces, digamos que también hay algunos factores que podemos utilizar y algunas escalas en esas evaluaciones que nos permiten prever ese riesgo y a tiempo ir tomando conductas en pro y que beneficien pues a esas personas que se encuentren ahí. ¿Qué se ha encontrado? Pues dentro de los estudios que respecto a bienestar y longevidad, cuando uno tiene muchas experiencias y emociones positivas, se ha visto que esto sí protege. ¿Para qué? Pues para tener en pro de un envejecimiento saludable, para estar con un envejecimiento exitoso. Entonces eso sí es trazador y sí es marcador dentro de esos determinantes que se van viendo. Hay estudios que se han hecho, por lo menos este se realizó en México, en Monterrey, donde estaban evaluando cómo era lo relacionado con bienestar y la interacción con la longevidad. Miraron una población desde los 55 hasta los 99 años, donde encontraron que realmente tener una buena interacción social, la salud, mis condiciones de salud, que no tuvieron un dolor fuerte, es decir, que sí habían unas cosas significativas, que incluido la autonomía, el ser yo autónomo, poder tomar el poder de decisiones es importante para la parte del bienestar y la salud mental, y que la escolaridad se vio significativo y se vio también relacionado respecto a lo que decía el estudio, que las personas que de pronto, que las personas consideraron que cuando tenían que a mayor escolaridad podían tener mejores posibilidades desde la parte económica, desde la parte de ingresos, y que esto también podía a ellos generarle bienestar. Entonces, en ese sentido, se vio en este estudio que, por ejemplo, la escolaridad fue un factor importante a tener en cuenta en este. Y lo otro que vamos a ver es que es importante el autoimagen, el autocuidado, el poder dormir bien, que yo tenga unas medidas para el control del estrés. Y algo que a veces olvidamos mucho o que se olvida mucho dentro de las consultas es la parte de salud sexual y reproductiva. Es una parte que nosotros debemos siempre, pues, hablar de este tema con nuestros pacientes, con las personas que vemos en el día a día. Es muy importante tocar esos tópicos de cómo se siente respecto a su salud sexual, si está satisfecha o no, para ver si nosotros desde nuestro rol como médicos familiares podemos hacerle alguna atención integral en este sentido, porque veo que muchas veces en consulta es algo que se olvida. Desde las escuelas, digamos, desde lo que tenemos acá en Javeriana, en Univalle, pues sí estamos como muy ligados a esta parte, pero hay veces uno ve como que hay esta falencia, y la idea es siempre preguntar pues por ese punto a los pacientes, que realmente es muy importante. Lo otro, quiero en este momento que miremos esta imagen, cada uno de donde se encuentra acompañándonos, y que de verdad gracias por estar aquí. Sabemos pues que es un día temprano, un día de descanso. Y me gustaría que ustedes, al mirar esta imagen, se hiciera cada uno una idea de qué le está pasando a esta personita que tenemos ahí en la imagen. ¿Qué tiene esta señora? ¿Qué le está pasando a esta señora? Y lo escribamos porfa en el chat, pues para que se pueda por ese medio leer las respectivas opiniones de los que nos encontramos aquí en el chat y podamos opinar por ahí. Entonces voy a dar un momentico como para que opinemos qué consideran ustedes que le está pasando a esta personita que tenemos al frente. Entonces, podemos ir viendo ahí en el chat, en los resultados que se están dando, que hay opiniones, algunas parecidas, algunas diferentes, y la idea es que nosotros siempre tengamos como una conciencia y una percepción de colocarnos en el lugar de esa persona que acude a nuestra consulta. Es una persona como nosotros también podemos estar en diferentes espacios en ese lugar como pacientes, y la idea es que nos hagamos conscientes de, primero, pues cómo puedo ayudar a esa persona, qué es importante, qué tiene, y también no llenarnos de preceptos, porque muchas veces podemos decir cosas como las anotadas, es que está triste, es que esta persona tiene algún dolor, es que esa persona, pero digamos, esta persona podría estar llorando de felicidad, realmente sí o no. Entonces también es como estar abiertos cuando llega el otro y acuda a nuestra consulta, a no tener como estigmatismos en ese sentido y dar la libertad para que sea ese paciente que nos escuche y podamos nosotros como hacer un abordaje adecuado de qué es lo que realmente está pasando con esa personita. ¿Qué es importante dentro de la consulta? Y aquí recuerdo algo que veía mucho con mis profes desde Javeriana Cali, y es que es muy importante también fuera de nosotros hacer el diagnóstico, fuera de nosotros hacer como la parte de tratamiento y saber decidir todo eso con las herramientas que día a día nos dan, tener esa capacidad también de comunicar realmente lo que queremos comunicar al paciente y que esto se haga de manera efectiva. Yo creo que esto es algo que nos sirve mucho a todos porque nosotros estamos en ese día a día, en ese diálogo continuo con las pacientes, educándolos, educando también a muchos que tenemos, por ejemplo, estudiantes, y la idea es hacer una invitación para que nosotros nos repensemos si realmente estamos comunicando efectivamente a esas personas que acuden a nuestra consulta, porque podemos a veces ser como unos expertos en la parte de diagnóstico y todo eso, pero vemos que los pacientes hay veces nos cuentan, es que fui a consulta y no me miraron, no me tocaron, no me dijeron, no me explicaron, solo me entregaron unas órdenes. Entonces como hacer conciencia de que inclusive hay técnicas para nosotros poder comunicar nuestras ideas, hay diferentes siglas o abreviaciones que se han utilizado, y la idea es motivarlos como para que las busquen y puedan en tal caso explorar estas y poderlas pues colocar en acogida dentro de lo que ustedes hacen en su consulta. Entonces una invitación para que tengamos pues como un paso a paso cuando estamos comunicando esas noticias, ya sean buenas o menos favorables para nuestros pacientes. Entonces me parece que es algo importante que debemos pues como recordar y que los invito a recordar en el día de hoy. Lo otro, tener en cuenta pues dentro de esos puntos claves que la idea es que al paciente, si requiere o a esa persona un apoyo desde la parte mental, no solo con equipo multidisciplinario, sino de psicología, de trabajo social, hay unas herramientas. También en la parte personal, pues tenemos que ver si el paciente está haciendo ejercicio, si hace alguna actividad de ocio, ya sea meditar, ya sea escribir algo que le guste al paciente, escuchar música. Entonces hay como muchas cosas que se pueden usar que vamos a ir determinando en la individualidad del paciente que tenemos en el consultorio. Lo otro es que en este día los invito, es que desde la parte emocional, nosotros como médicos familiares, pues también es importante que tengamos pues nuestro apoyo emocional y todo. Aquí traigo una foto de los grupos Balin que estuvimos trabajando desde SIN, desde Huaynacay, con apoyo de WONCA y todo. Nosotros estuve por lo menos participando en grupos Balis como desde el 2020, como hasta el 2022 más o menos, que se acabaron los grupos. Me parece que es importante también mirar la posibilidad como propuesta que dejo de esta presentación, es que hagamos la reactivación de los grupos Balin. Nosotros nos reuníamos una vez al mes o cada 2 meses y hacíamos un Balin iberoamericano. Era una actividad muy chévere y también era una actividad de apoyo en la parte de la salud emocional. En Panamá hay personas que me preguntaron de los grupos Balin. Yo no los lideraba en ese entonces, pero la idea es que lo dejo como propuesta, pues para ver si desde la parte de salud mental, pensando en nosotros que somos cuidadores, que vamos a cuidar a otras personas, pues pudiéramos hacer la reactivación, y lo dejo como propuesta. Y ya para terminar, quisiera que cada uno en este espacio abra su cámara. La idea es que ustedes estén con la cámara abierta, y después de abrir la cámara voy a dar estos 10 segunditos para que cada uno o los que puedan o estén en disposición de abrir la cámara lo hagan, para que hagamos esta actividad cortica. Nos vamos a demorar solo 1 minuto, y la idea es que yo les digo en qué momento, a partir de qué momento voy a contar en el cronómetro 1 minuto. Antes de empezar el conteo, yo les voy a dar la indicación para que ustedes cierren los ojos, mantengan los ojos cerrados, y cuando ustedes consideren, con, manteniendo sus ojos cerrados, que ya pasó 1 minuto de tiempo, van a ir levantando la mano y abriendo los ojos. Entonces, ustedes consideran en qué momento ya pasó el minuto. Yo voy a ir cronometrando. Cuando el tiempo me dé a mí el minuto, voy a alzar mi mano también. Entonces, voy a contar hasta 5 para que, si ya veo que ya varios han abierto las cámaras, la idea es que se unan a esta actividad, que esta ya es la casi última diapositiva. Entonces, abrimos las cámaras, los que puedan. Voy a contar hasta 5 para que cierren los ojos, y ya saben que voluntariamente yo no voy a dar la indicación, sino que ustedes, cuando lo consideren, ustedes van a abrir los ojos en el momento que ustedes consideren que ya ha pasado 1 minuto de tiempo. Entonces cuento hasta 5 para que cierren los ojos. 1, 2, 3, 4, 5. A partir de ese momento, cerrar los ojos. Y cada uno lo va a abrir cuando considere que ya pasó 1 minuto de tiempo. Listo, ya podemos abrir los ojos. En este momento es 1 minuto y 30 segundos. Cuando yo levanté la mano inicialmente, habían solo 3 personitas por ahí que coincidieron o se aproximaron mucho al tiempo. Y la idea con este ejercicio es ver cómo para nosotros hay veces hasta el conteo del tiempo es diferente. Entonces la idea con esta reflexión es que nosotros no podemos asumir porque a una persona le pase X o Y cosa, cómo está respecto a la carga de salud y de la parte pues como de la enfermedad mental, sino que digamos que es algo muy individual. A mí me puede pasar lo mismo que a una persona, pero mis herramientas desde la parte emocional, desde la parte de bienestar, puede ser que no sean iguales y que yo no actúe de la misma forma respecto a esa situación. Entonces la idea es a tener conciencia que como así nosotros no nos colocamos de acuerdo hay veces en el tiempo, pues la idea es no estar haciendo un precepto y un prejuzgamiento de las personas que de pronto están padeciendo algo desde la parte mental, desde la parte pues de su bienestar y poder ser ese apoyo con las personas, poder ser ese apoyo de que de igual manera por la misma causa puede ser que una persona requiera un apoyo diferente, un apoyo más largo, un apoyo más corto, pero que ese actuar va a depender mucho pues de la forma individual, de lo que encontremos en esa persona, todas esas herramientas en sus diferentes componentes. Y ya para concluir, pues tener en cuenta que esa salud mental va a influir no solo en la calidad de vida, sino que influye en todo, en nuestra capacidad de lo que pensamos, de lo que sentimos, de nosotros, cómo nos relacionamos con los demás. También va a influir mucho cómo nos vamos desarrollando y tomando las decisiones a lo largo del tiempo. Es algo que va a estar ahí presente, presente siempre. Y por eso la invitación más que todo en el día de hoy es hacer conciencia de que nosotros dentro de nuestra formación hay unas cosas y hay unas herramientas que ya tenemos que podemos poner en uso, no solo para nosotros, sino también para los pacientes que nosotros día a día estamos atendiendo. Entonces, con eso termino y muchas gracias a todos por su participación.
Thank you very much, Dr. Liliana Villegas. And we also thank Dr. Anna Perez for the translation and interpretation. I know it's not easy at all. We have learned a lot about self-care in mental health, and 1 minute exercise is very inspiring. For myself, I pass way beyond 1 minute. It means that maybe I'm very tired. So our final speaker would be Dr. Fajer Dashti. She is a senior registrar in family medicine and holds a master in diabetes management from Warwick University and a diploma in pediatrics from Royal College of Physicians of Ireland. She is Kuwait representative in ORASI, which is our Young Doctor Movement in East Mediterranean region. Dr. Fajer is passionate about collaborative approaches to physician well-being and has been actively involved in initiatives aimed at improving mental health support for healthcare professionals. In her presentation, No More Superheroes, a collaborative approach to physician well-being, she will discuss how teamwork and collaboration can enhance our resilience. So after learning from the personal level, now we go to the organizational level. Let's warmly welcome Dr. Fajer. The floor is yours, Fajer.
Hello, greetings everyone. Thank you, Dr. Cheryl, for facilitating this webinar. Allow me a minute just to share my screen. Hola. Okay, so I really enjoyed the presentations of my previous colleagues. Dr. Mya talked about their organizational interventions to tackle the issue of burnout, and Dr. Liliana talked about the individual approaches on how to tackle the issue of burnout. So I will elaborate more on the organizational approach. So we all agree that burnout is a serious problem. There has been numerous studies and publications on the effect of burnout in terms of financial cost on the healthcare system, in terms of malpractice lawsuits, taking frequent leaves, or even leaving the workforce altogether. There has also been numerous publications on the effect of burnout on patient safety. But we don't want to talk about the clinical practice only. The feelings of burnout, we take them with us home. By the end of the day, when we go home, we are human beings in the end. And these feelings continue even in our personal lives. They affect our sleep, they affect our mood, they affect our health, they affect our relationships, being able to take care of our family and loved ones. And that can lead to anxiety and depression, self-medicating with substance misuse, and even suicide ideations. So tackling the issue of burnout is a serious problem. Yeah, can you hear me? Okay. Okay. So why is burnout is a hot topic right now? We all know that medicine has always been a high demanding job. When I was a kid, I used to watch the show ER, you know, the young George Clooney, and they are running in the ER and they are hectic and they're working like a beehive. And this was exhilarating. I wanted part of this job. Every patient is a quest, every soul is a conquer. This was exhilarating and we were okay with it. Why now are we talking about burnout? Because when we signed up to be physicians, we signed up to stress. Stress is a normal response to the overload that we feel. Stress means that it pushes us to do more, to try to work harder, and it makes us proud by the end of the day. We feel self-accomplished. And then when we take time off and we go on a vacation, we can enjoy it and then go back to work. But burnout is different. We did not sign for burnout. Burnout continues throughout the day. And even if we take a break, we cannot enjoy it. And no matter what we do, we still feel that there's something missing. We did not agree to feel burnout. We agreed to feel the stress, which is okay. Why now everyone is talking about burnout? Dr. Maira has presented a wonderful presentation about burnout, but this issue has been there for a long time, even before COVID. This is a study that was published in the British Journal of Psychiatry in 2017. And as you can see here, the burnout scores for emotional exhaustion ranged up to 54%, depersonalization up to 44%, and low personal accomplishment up to almost 40%. And general practitioners have the highest scores. This is from the Canadian Medical Association. They did a survey in 2017, and then they repeated it again in 2021. Once again, burnout 53%, low personal fulfillment 8 out of 10, so that's 80%. And career dissatisfaction is almost 1/4. And if you can see here, they wrote, this is probably what contributed to the current shortage of physicians across Canada. People are leaving the work they have worked very hard for. If we want to look at things globally, this is, in our area, the EMR, this is a study that was done after COVID in the EMR region. They looked at doctors from 9 different countries. And once again, almost 60% had depression, almost 60% had anxiety, and more than 40% had stress. And the number of them who had it in a severe form is also huge, around the 20%. So this is to show that burnout has nothing to do with the way your practice is run, the number of patients you are seeing, or your demographic or your population you are serving. All of us across the globe are suffering. Why is this happening? What has changed for family medicine? Back in the days, we all saw the movies when the doctor, the family medicine, would take his magic black bag and he'd go to someone's house and somehow the bag had everything he needed. And they would see the patients and they would treat the patients. Right now, we are spending less time with the patients and more on the computers. We are busy with documentations, coding, health records, insurance authorization, performance reporting. Studies show that we spend twice as much time on the healthcare records than with the patients. On average, if the working hours are 11 hours, we are spending 6 hours on the health records, 4 hours during our clinic hours, and 1 to 2 hours after working hours just to keep up with the documentation, which is called the pajama time phenomena. The healthcare records were supposed to be efficient and convenient way for the doctors to keep up with the information of their patient, but only 30% of doctors are satisfied with how the electronic records are set. They are time consuming, they increase the cognitive load, their interface is non-intuitive, they are fragmented, cannot find the information, you have to fill out multiple places, and it's taking away from our time that we spend with our patients. Treating medicine as a business model, the industrialization of medicine that is happening nowadays is also causing burnout. We are trying to see more patients in less time. The British Medical Association recommends 25 consultations per day, around 15 minutes per each, but we are seeing much more than this number and for less amount of time. We are not allowed to see the patients more. We're trying to spend less time with them. There's fragmentation of care, the administrative distraction, and it's also taking away from our time. Metric-driven culture. There is a rise of pay for performance, dashboards, and performance indicators, and it shifted the focus from the quality of care to the quantity of it and numbers. If you look at any press release for any health organization, they're always bragging about the numbers. This clinic saw this many patients, this country saw this many patients. We are seeing more patients, but they are getting sicker. If you look at the prevalence of diabetes, complications of diabetes, obesity, children neurodevelopmental problems, anything, they're just getting more and more and more. But we are seeing them. We are seeing all of them. We are seeing them multiple times. Why they're not getting better? Because we are compromising the quality for the quantity, and that puts a load on us. We are losing our clinical autonomy. For us as family physicians, we take pride in our decisions. We take pride in the knowledge that we have gained over the years. We gain pride in our ability to manage our patients, but our hands are tied. We are faced with many protocols, performance metrics, and insurance restrictions that limits our practice, limits what we can do for the patients. It's going from, it's called a top-down decisions. And that also puts a burden on our soul, basically. After COVID, there has been a huge distrust of the public in the healthcare system. And to compensate for that, the healthcare system is pushing family physicians to work more, to provide more. And once again, this takes away from our ability to function. We are required to do more on-call shifts, to see patients after hours, to answer their messages, just to gain their trust back. And this is not ideal. So much to do and not enough time to do it. If you see any doctor influencer on Instagram, they always make this joke about family physicians spending so much time on their administrative work. And this is true. We do a lot of administrative work, more than any other specialty. Doctors say that the Canadian Medical Association has estimated that we spend more than 10 hours per week on administrative duties, and it puts a load on us. For every 10% decrease in the task force, the burnout decreases by 33%. For every 10% less administrative work. 90% of primary care physicians feel they spend too much time on administrative work rather than focusing on their patients. And there's an issue of role ambiguity. When we are working, we're supposed to be seeing patients, and that's it. But we are expected to be the jack of all trades. We are supposed to coordinate with the pharmacy. We are supposed to do the job of the pharmacy by explaining the treatment to the patient. We are supposed to be social workers. We are supposed to be technicians. When the computer or the printers are not working, we are supposed to take care of that. We are supposed to handle the problems with the reception. We are doing everything. So there is a role ambiguity. Most of the literature estimates that family physicians, there should be one family physician per 1,500. And if you're working in a proper setting with multiple team members, you can increase that number up to 2,500. But this is not applicable everywhere. If you want to provide the proper care for acute cases, acute problems, chronic problems and preventive care for every patient under your care, assuming that it's 2,500, which is the average nowadays, you need to work 22 hours per day just to fulfill this criteria. And the problem is that we are not reimbursed for the chronic follow-ups or the preventive care. We are only measured on the acute cases and how much we prescribe. But we spend most of our time in counseling. We spend more of our time on prevention and the holistic approach and the psychosocial, and we are not reimbursed for it. And we have to take away from our consultation time. And we feel bad by the end of the day. And this also causes burnout because we are not feeling fulfilled. This is not the family medicine we signed up for. Most of primary care practices feel that there is an organizational injustice whenever the higher-ups, regardless whether you're working in a private practice or under the government, whenever they are distributing the funds or the resources, primary care always gets picked last. And this, once again, we feel that there is an organizational injustice. We feel lack of respect, we feel underappreciated. And once again, we don't feel the motive to work anymore. In our work, there's a lot of workforce shortage, and especially during leave, there is no one to cover for us, and we have to pick up the slack. We are always required to open more services. A lot of primary care practices are required to do also well-baby clinics. We have the women's health, we have the NCD, we have the diabetes, we have the psychiatry, we have the geriatric, but we are not, it's not being matched with the proper resources. We need more clinics, we need more resources, we need more nurses, and we are not just getting that. We are just getting the orders without getting the support that we need. There's poor leadership and management. A lot of the management, or when you seek help from someone, they are not well equipped to manage any problem in the workplace. If you feel burnout, if you feel you have any problem and you reach out to the leader in your setting, they are not equipped to help you. There's a lot of dysfunctional organizational politics, there's bureaucratic demands, and there's the problem of the toxic environment. We are, again, because of the industrialization and the business model, it's becoming very competitive. We are not working as a team. We are just trying to fight each other for the best chances for promotion and so on. Once again, no one is listening. This is a quote in one of the journals. In training, we learn to believe that our value is in our sacrifice. Prioritizing our well-being is selfish. We do not take time off when we are unwell. We are strapped for time for exercise, eat well, and nourish our relationships. We learn to be cogs in a giant wheel, one that we dare not slow down, even at the cost of our own lives. We are expected that this is part of the job. No, it's not, okay? Suffering is not part of the job, okay? And doctors who seek medical help or seek, like support in any way are deemed sick. They are deemed incompetent. They are deemed that they have problems with time management, leadership skills, and they are stigmatized, and they lose their promotions for any, they lose their chances for any promotion just because they cannot keep up with their peers for any reason. The organization believes that it's our job to take care of ourselves, which is not true. It's supposed to be a team effort. We are expected to show up for work even when we are sick, and we are penalized if we take time off. And so even when we are facing severe burnout or severe problems, we do not think that they are severe enough to take time away from work, and we still show up. And that's accumulatively puts more strain on us as well. Once again, there's the stigmatization of help seeking, whether it's there's physical barriers or cultural barriers to accessing support, and there's fear of professional repercussions and inadequate support system, as we have said earlier. Once again, we said that managers are mostly ill-equipped for this role as support and being in mentorship. Only 4 out of 10 employees feel comfortable discussing their mental health with their supervisor for the fear of repercussions, or just feel that it's useless. They don't know how they can help us. This is a meta-analysis that was done in 2023 in the BMJ. They looked at all the studies that are discussing interventions, evidence-based intervention to managing burnout. If you look here, interestingly, the studies that focused on individual-focused interventions, individual-focused intervention to managing burnout, there are so many of them. But when it comes to the organizational-focused interventions, there were only 3. Yet, we are taught to talk about any problem, and there's a primary prevention, secondary prevention, and tertiary intervention. When we talk about self-care and how we can manage burnout, this is actually tertiary, right? Because I already feel burnout and I'm trying to minimize the consequences. This is tertiary. Why are we focusing on tertiary prevention when the problem should be primary prevention? I should not feel burnt out in the first place. The working environment should support me that I do not have to feel burnout, and then I do not have to take the interventions by myself. So this is a legal and moral responsibility from the higher ups all the way down to myself, and not the other way around. We start from the overreaching context, lobbying and politics. We have a lot of the associations for family medicine, organizations for family medicine. They should be lobbying the politics and the protocols in our favor. Then we talk about the organization, whether it's if you're working in a private practice, there is your like the head of your practice. If you're working in a government such as myself, again, the government should take care of me. Then it's the head of my clinic, and then it goes to myself. So what are the organizational focused intervention? I cannot give you like a roadmap, because once again, our practices are different. The way family medicine is run in Kuwait is different from your countries mostly. So I cannot give you like specific instructions, but these are the general guidelines. There's something called job crafting. Job crafting means that you we have the liberty of changing our role in the practice. Some of us like to do the administrative work, go do that. Some of us like to do teaching, go ahead, enjoy it. Some of us like to see patients, yeah, go ahead, have fun. We should be at liberty of deciding our role inside the organization, but expecting us to do everything all the time is not ideal, okay? This is one thing for the job crafting. It's personal weekly goals that promote teamwork and increase the quality of care for the healthcare workers. Once again, delegation. We are not supposed to do everything. If we want to fill out the paperwork, then we should be having assistants that can do that. If we want to take vitals for the patient, we should have a nurse that can do that. If we want to keep up the appointments, bookings for the appointments, there should be someone to do that. It should not be my job only. So job crafting and employing other people can help me. And there's the peer support network. There should be someone who is delegated and equipped and trained to provide the emotional support. They should be able to spot the signs of burnout. They should be able to reach out to people at risk. If they know about any situation that I'm going through and they know I am at risk of burnout, they should reach out to me and they should provide the support. There should be someone that is delegated to take care of my mental health, and this should be a protected right for me. This is not a privilege. Someone should be in charge of providing protection for my sanity. When we studied in the residency program, we were taught about something called housekeeping. If you're feeling overwhelmed in the clinic, whether it's a patient or a case, or you personally cannot just go through the rest of the day, housekeeping, you're supposed to take time off for the day, but it's not a protected right. It depends on the flow of the clinic. If there's someone to cover for you, it should be a protected right, and someone should be in charge of doing that. There's some, this is for the setting in the clinic. There's something called individual job crafting. As we have said earlier, if you like to do the administrative work, you can do that. If you want to do more of the teaching, you can do that. If you want to do anything, you should have the liberty of deciding what you want to do. When you know your weakness, this is by itself a strength, because then you can shift your focus on what you are really good at. This is not something that should be held against you. So there is task crafting, which is changing the number, type, and nature of your tasks. in order to fit your health, to fit your traits, to fit your interests. There's relationship crafting, changing the number of your interaction at work, whether it's with your colleagues, whether it's with your patients. And there's cognitive crafting, changing your perspective on your work. It can be hard sometimes to focus on the positives, but we should keep reminding ourselves why we are doing this in the first place. Finding the purpose and the joy in our work can help take the load off sometimes. So in summary, general ways how we can improve the practice. The workload management, like we have said, either we increase the number of family physicians or we decrease the load of the patients that we are required to see. Our time should be allocated between seeing patients or doing administrative work, and it should be a protected time for us. We should not be doing this out of hours or doing 2 tasks at the same time. We should be allowed to have longer consultations in order to provide the care that we are happy with. Once again, there should be protected breaks, there should be protected non-clinical time, and we can hire someone to do the documentation and the paperwork for us. Redesigning the models for primary care, it should not be focused around the family physician. There should be other team members with us, including a clinical pharmacist, a behavioral health practitioner, nurses, care coordinators, and GP training. The WHO and for EMR have introduced something called the GP diploma, which is training the GPs. In this context, just want to point out that we have family physicians who are board certified, and there's the GPs who are not board certified. Training the GPs to take the load off from family physician will help tremendously. They can do a lot of the work that we can see. They can cover the acute cases. They can do follow-up for chronic patients who are stable. They can do the screening for the preventive care, and that takes the load off me. We actually have a program here in Kuwait for the GPs, the only one in the region as far as I know. And once again, instead of giving one family physician per 2,500, there will be, for example, one family physician and 3 trained GPs for the 2,500. And they report to the family physician, and that will decrease the load. Simplifying the administrative work using a more friendly electronic record. Once again, the leadership and cultural changes. There should be a physician well-being officer or a burnout leader. They should be trained to recognize burnout, to foster psychological safety, and encourage collaborative decision-making. When we give our feedback to those in the higher up, it should be taken into account. It should be taken into account. A lot of times when we speak up, whether on like an individual level, when you speak to your supervisor or the associations or the associations, basically, when they talk, they always think that the higher ups, they always think that we are trying to get out of work. And operating in ill faith also puts a strain on us. They are pushing us to do more. And when we give them alternative on how things are supposed to be done, there is always the issue of us thinking that family physicians are trying to see less patients. We are not trying to see less patients. We are trying to do better work for these patients. So it's not only about the number. Our input should be taken into consideration when they are doing the protocols, when they are doing any form of legal actions. We should be allowed flexible working hours. We should have more authority over our working schedule and the numbers of patients we see. And once again, there should be protected time for teaching, research, and administrative work. It should not be during my clinical work or out of office hours. And once again, there should be a reduction in the on-calls and so on. It's very important to recognize the red signs when you really need someone. And once again, there is no shame in admitting that we need help. We are humans in the end. When your thoughts, emotions, or behaviors are out of control and they are affecting your life, when you are struggling to deal with your playful challenges or you're unable to handle them, when the unhealthy coping mechanisms such as smoking, substance misuse, or eating behaviors are interfering with your life, when you are confused, distressed by emotions and need the perspective of an unbiased person, when you feel hopeless and life is not worth living, you have to reach out for help. But the problem is that we need someone who is qualified to give us that help. That concludes my presentation, and that's it. Thank you so much.
Thank you so much, Dr. Fajer, for this comprehensive presentation. We all learned that it's very important to put on your own mask first before helping others. Whenever we go on an airplane, the flight attendant will say, "Put on your own mask first." It also applies when we are dealing with our own mental health. And we have to note that it's not being selfish to take care of yourself. It's also being professional in taking care of yourself, because you can then take care of your patient. And today, we know that physician burnout is a serious topic. It affects not only individual doctors, but also affects the whole system. The system can be fatigue and burnout as well. So we learned that we learn from our speakers how to prevent burnout from various level, either it's personal level, institutional, or organizational level. Once again, I would like to thank all of our 4 esteemed speakers. And now we have around 15 minutes for a Q&A session. If you have any question, please raise your hand and I will cue your name. When you ask your question, you can introduce yourself and say, where are you from? And then direct the question to one of our speaker. We open the floor for any questions. Or any kind of sharing. You can share with us your personal tips for preventing burnout in your system or in your country. It will be all very welcome. There is a hand from Dr. Alejandra.
Hey, Cheryl. So I was thinking in the previous presentation of Dr. Fajer, and we're really hard workers, but sometimes say no to others is say yes to ourselves. So I want to say that.
Yes, I also want to share that when we take up responsibilities, it's really important for us to assess your own capacities. Like being doctors, we are always saying yes. You say yes to all your patients, you say yes to your seniors, especially in Asian culture, when the seniors assign a task to us, it's very uncommon for us to reject the task. So sometimes, like if you're a capable doctor, if you're an excellent trainee, you get loads and loads and more jobs ahead of you. So sometimes it's very important to prioritize your own needs and prioritize your life. And sometimes saying no is also a means of being prioritizing your own mental health. Oh, Brenda, I see your baby.
I left the question in the chat because I have a lot of background noise here.
Any other questions or sharing? If not, I think we can take a big group photo together. If you don't mind, you can open your camera and say hi to all our friends from all over the world. We have had a very successful webinar. During the whole webinar, our participants number has been 100 and many times exceed 100. I have people keeping in the waiting room and I cannot admit them all. The webinar will also be uploaded to WONCA's YouTube later on.星星，很高兴见到你。
If I could say something,
Yes.
the number of people who are joining the webinar, it just shows that we are all suffering together, but all of us have this little guilt that maybe I am doing something. Maybe, like you said, maybe I am taking too much task. Maybe I am not managing my time. Maybe it's something about my personality. But no, we are all suffering, and once again, it's not our fault.
Yes, we on this World Family Doctor Day, we want to thank all doctors in all over the world, all family doctors. And it's time we prioritize ourselves as well. Okay, let's have we have John. Hi,
Yes.
John.
Hi. Thank you for a good webinar.
We can't hear you. You have to unmute yourself.
Do you hear me now? Yeah. So thank you for a good
Not
webinar.
yet. We cannot hear you.
Okay.
I could hear him. Maybe Cheryl, you're on a different channel or something.
Yeah, I think because I could hear him.
Okay, so I will speak. So thank you for a good webinar from Sweden.
We can't hear you.
In Sweden, we are unfortunately a bit sad for the 4th place in Eurovision, but I would just like to add that the diagnosis here in Sweden.
Very interesting, but John, we cannot hear you. Maybe can you take off your earphone and then try to say that again?
Cheryl, I think maybe you are in the Spanish channel.
Oh, I see.
I can hear him.
Oh, okay. Sorry.
Last try. So in Sweden, the diagnosis burnout or utmattningssyndrome will disappear in 2028. Just something to mention for this interesting discussion, how you view that when we remove something and then, yeah. So if one of you would like to just to comment on that, thank you.
I think it goes back to what we said, that they're turning medicine into a business, and we are expected to keep working and do more. And burnout, like, once again, there is a distinction between burnout and stress, and maybe some people don't understand the difference. But burnout is a real phenomenon, and some people think that it's not. Either you are clinically depressed or you are fine. But burnout is a real phenomenon, but we are expected to do more. Removing this diagnosis from the medical practice is just an excuse for us to work even more. And once again, filling in the agenda that everything is a business. And this is how the world is going. Now we're going into this direction of capitalism, and money makes the world go around. So this is turning into an industry. But we should practice what we preach. We keep telling patients to work on their health, on their mental health, yet we are the ones who are at fault, and we are not considering this. But I don't think it should be removed. Maybe they don't want people to take a personal day and they should keep working, but it should be acknowledged.
Thank you so much, everyone. So I think it's time that we call it a day. And happy World Family Doctor Day to you all. It's time to go to bed for me.
Happy
And
World Family
prioritize my
Day.
own sleep. Have a great day.
A big hug to all of the tías and
Thank you
tíos.
all. Bye-bye.
Feliz Día del Médico Familiar.
Thank you.
Felicidades. Tía Ale, tía Lili, Aunt Cheryl,
Wow.
tía Anita.